Um, First of all,
Professor,
I'd like to send a big. Sorry. Are you going to introduce it, or should I start just immediately?
yes. Um Firstly, I would like to thank our TASL President, Professor Dr. Ramazan Yıldırım, Professor Fulya Günşar, and Basel. We have been watching a very nice meeting for 2 days. I think one of the most important sessions of meeting is our session because the main challenge in Delhi is diagnosis. Therefore, I do believe that this session will be beneficial for all of us. First speaker, Professor Bülent Değertekin. He is a very famous hepatologist in Turkey. Please, Bülent.
First of all, okay. First of all, I'd like to thank you, and I'd like to send a big hi from Turkey to everybody out there. Well, today's session is about causality assessment and the diagnosis of DILI. And my job today is to talk about laboratory workup, imaging, and the role of liver biopsy in diagnosing drug-induced liver injury cases.
I do believe that this session will be beneficial for.
Okay, so I'm continuing.
All of us. First speaker, Professor Bülent Değertekin. He is a very famous hepatologist in Turkey. Please, Bülent.
Okay. First of all, I'd like to thank you for your kind invitation. First of all, I'd like to thank you, and I'd like to send a big hi from Turkey to everybody out there. Well, today's session. Okay, so first of all, I'd like to send a big hello from Turkey to everybody out there. I'm Dr. Bülent Değertekin from University of Acıbadem School of Medicine. Today's session is about causality assessment and diagnosis of DILI, and my job today is to talk about laboratory workup, imaging, and the role of liver biopsy for the diagnosis of DILI. So here's the main topics of my talk. I'll start by talking about the difficulties we're facing for the diagnosis of DILI. And later on, I'll focus on the correct diagnostic approach. I mean, the steps we should follow. And later on, the role of liver laboratory workup, imaging methods, and liver biopsy. And lastly, I'll try to mention about something new. And as of March 2021, what's new in the diagnosis of drug-induced liver injury. So let's move on. So first question was, why is it so difficult to diagnose DILI cases? Well, because it's just most of the cases are totally unpredictable. It's just like winning the lottery. I mean, you cannot predict who will experience it and when will it happen. Another important thing is we don't have any diagnostic tests specific to DILI, and that makes things worse, actually. And another thing is that we don't have good methods to show causality assessment. And beside all these negative factors, I mean, DILI is like a clown. I mean, it can mimic every type of liver disease. It could present in the clinic with just asymptomatic enzyme elevation. And the other side, it could just present with acute liver failure, vascular diseases, granulomatous hepatitis, chronic liver disease. So it has many types that can present in the clinic. So at the end of the day, what we do is we trust our son's clinic. I mean, the expert, the clinician just looks at the laboratory results and looks at the patients, looks at the liver damage, and believes that it is related to this medicine, or it could be that causality agent that's causing all this liver agent. But for a successful approach, we really have to go step by step. I mean, initially, we have to determine the presence of liver injury. And that's where laboratory workup comes in handy. And after detecting the presence of liver injury, the second step is determining the type of liver injury. Is it hepatocellular type of damage? Is it cholestatic type of damage? Or is it a mixed one? And after finding the type of liver injury, then we go for an extensive differential diagnosis for these patients. And we try to exclude all possible insults. And at the end of the day, if we can't find anything, then we blame the causative agents. But step by step, it's detecting the liver injury, determining the type of liver injury and excluding all possible insults. And at the end of the day, we only have the causative agent in our hands. And laboratory workup is the key to follow all these steps. So what do we have? For determining the liver injury, of course, we have the ALT and AST. If ALT and AST is high, we say that the patient has hepatocellular injury. If alkaline phosphatase and GGT is high, we believe that there's cholestatic injury. And if the bilirubin is high, INR is high, and albumin is low, so we say that things are more serious and the liver is deteriorating very fast and the patient might go for acute liver failure. But after determining this liver injury, we have to find the pattern of liver injury. And in that way, we use the R value. It's actually easy to calculate the R value. It's just serum ALT divided by alkaline phosphatase. And once you have the R value, if it's above 5, that means your ALT is quite high relative to the alkaline phosphatase ratio. It means there's hepatocellular damage. If the R value is below 2, that means you have cholestatic damage. And if it's in between, it means that you have a mixed pattern of liver injury. Why is determining the pattern of liver injury so important? Because we will have an idea about prognosis. It will guide us for differential diagnosis, and the list of causative agents are classified according to the pattern of liver injury. So if you have a patient who has hepatocellular type of damage, you'll go with these possible agents. And if you have a mixed one, you have to check this possible causative agents when you're dealing with DLE patients. So what do we do after that? I mean, we saw that there is injury, and we found the pattern. Then we go for differential diagnosis and we try to rule out other diseases. So if the patient has hepatocellular injury, that means we have to rule out acute viral hepatitis. So we have to order the acute viral hepatitis serology for hepatitis A, B, C, and in countries like us, especially Delta, and especially hepatitis E. And acute hepatitis C should always be in our minds. Autoimmune hepatitis serology is the first-line test that has to be ordered whenever we see a patient who has hepatocellular injury. And ultrasound is a must as a first-line test when we're dealing with the hepatocellular injury case. But at the end of the day, if we somehow don't find anything with all these tests, then we move on to the second-line test. If the patient is young, we should order a ceruloplasmin level to understand whether the patient has Wilson's disease. And we should order serology for less common viruses like hepatitis E, CMV, and Epstein-Barr virus. And liver biopsy is always on the table. I mean, whenever we get mixed up and we want to understand what's going on in the liver, we could go with the liver biopsy. But all this should be decided on case-by-case basis. So how about cholestatic injury? If the R value is below 2, I mean, what are we going to do? Then we have to rule out all the cholestatic type of liver diseases. As first line, it's the ultrasound. I mean, it could just be the gallstone in the common bile duct. It could be just acute cholestasis. So we have to see the ultrasound. If somehow we find that the ultrasound is normal, then we go with the second line test. We could order the MRCP, we could order serology for PBC, and of course, we could go for the liver biopsy for these patients as a second line test to understand whether there is any particular reason that could cause all this cholestatic injury. How about mixed one? Mixed one is same like the hepatocellular one. We have to rule out acute viral hepatitis, acute hepatitis C, autoimmune hepatitis, and we have to go with ultrasound as first line. And then the second line is just like the hepatocellular injury type, ceruloplasmin, serology for less common viruses, and maybe liver biopsy might be handy in these patients. So to sum up this part of the talk, I picked this table from a nicely published study for a couple of months ago in Hepatology Communication. If we see a patient with significant liver injury, we have to perform a detailed history and physical examination and detailed medication history. And after that, we go with the R ratio and we try to find the pattern of liver injury. And according to that, we move on to the differential diagnosis phase. And based on the type of injury, we order the test and we try to find particular reason to understand why the patient has this liver injury. And if somehow we rule out everything, we don't find any particular reason, then we blame the medicine and we say that this is possible drug-induced liver injury. So I'd like to talk a little bit about liver function tests. Well, we should always keep in mind that minor increases in ALT and AST should not be classified as DILI. And these are believed that it's the adaptive response or maybe reversible response of the liver, or maybe there may be fatty liver in the background of the patient. So minor increases like in statins, in ALT and AST should not be classified as drug-induced liver injury at the initial phase. But hepatocellular injury is something different. It is the most common pattern of drug-induced liver injury. It makes about 50 to 75% of the total DILI cases. And we know that hepatocellular injury, patients with hepatocellular injury tend to be younger. They're less likely to be jaundiced, but they have higher frequencies of liver-related death and is 2-3 times more likely to lead to liver transplantation. So how about chronic DILI? Liver function tests can also be used to diagnose chronic DILI, which makes about 5 to 20% of the total DILI cases, which is quite high. Well, we know that the clinical course tends to be more protracted in patients with cholestatic injury, but if there is persistently elevated total bilirubin and persistently elevated alkaline phosphatase in the second month from the DILI onset, we should be concerned about chronic drug-induced liver injury. So what are the cutoffs? If the total bilirubin is above 2.8 times the upper limit of normal and alkaline phosphatase is above 1.1 times the upper limit of normal 2 months after the DILI onset, then we should think about chronic drug-induced liver injury in that specific case. But liver function tests, they sometimes does not always reflect liver injury, and especially in patients with indolent fibrosis, in patients with vascular liver disorders, cirrhotic patients, and microvascular stenosis secondary to mitochondrial toxicity, the LFTs does not always reflect liver injury. In these cases, and in general, we should always remember that the decisions must always be based on an individual base, and maybe especially in these cases, liver biopsy may be preferred earlier to understand what's going on in the liver and to demonstrate the damage in the liver. I'd like to say a couple of words about bilirubin, which is very important when we're talking about drug-induced liver injury. It does correlate with mortality. Hy Zimmerman is the first person who said that a constant serum bilirubin above 2 times the upper limit of normal plus an ALT 3 times the upper limit of normal is associated with a mortality approximately of 10%. So that's quite high. And this finding was confirmed with the Spanish DILI network and the Swedish network. And if you have a patient who has drug-induced liver injury and has high bilirubin plus high ALT levels, yeah, we really should be concerned about mortality, and it's about 10%. So how about imaging modalities? Do we have any miracle imaging that will tell us that the patient is DILI? Well, unfortunately, no. Liver imaging in DILI is typically normal. But there are some things that I'd like to mention. All patients with suspected DILI should undergo an ultrasound. And MRCP, Doppler ultrasound, CT scan, it should always be considered case by case, and especially the cholestatic ones. For the cholestatic ones, it could be considered. We should always remember that 10% of DILI cases have secondary sclerosing cholangitis-like changes in MRCPs. These are not primary sclerosing cholangitis cases. These are sclerosing change cholangitis caused by the medicine, and 10% is quite high. So whenever we see a patient who has cholestatic type of liver damage, liver disease, and we should go with the MRCP, and we should consider the differential diagnosis. So how about liver biopsy? Well, typically a liver biopsy is not necessary to establish a diagnosis of DILI. It's not a must, but to exclude other etiologies for liver injury and to assess the degree of inflammation and necrosis, we sometimes perform liver biopsy. So which cases, we should go for liver biopsy? If there's persistence of altered LFTs or signs of worsening liver function after washout. This means we stop the medicine, but the LFTs are still high, or the patient is just worsening, and the liver is still worsening. And in those cases, performing a liver biopsy is a good idea because the patient might not be DILI, or maybe the patient is a chronic DILI case. Some authors believe we should perform biopsy according to Hy's rule. Some believe we could perform liver biopsy after 60 days, starting from the acute insult. But I mean, this paragraph clearly says that if the liver is worsening or if the LFTs are still high and it's not getting back to normal, we should go for liver biopsy. A second option is for the liver biopsy is autoimmune hepatitis. If the serology is positive and if we have concerns about autoimmune hepatitis, it's a computing etiology, then we should go for liver biopsy. And the third one is that if we're going to continue using the medicine that has caused all this damage, if there will be re-exposure in the future, then these patients should go for liver biopsy while they have drug-induced liver injury. Liver biopsy also could give us an idea about prognosis. I'm not going to go in detail, but we know that if there's granulomas and if there are eosinophilic infiltrations, I mean, the liver injury, we say that it's mild to moderate. And there are signs, I mean, if there's high degree of necrosis, high degree of fibrosis, if there's cholangitis, cholestasis, I mean, we believe that the patients will, there's severe liver damage and there might be death and liver transplantation for this patient. So what's new? There's a new kid in the block. It's machine learning and artificial intelligence. Like in all fields of medicine and all of our life, AI it's really coming on drug-induced liver injury diagnosis way. There are many published studies in the literature on this topic, and there's this machine learning algorithms for predicting drug-induced liver injury, and they really publish good results. The accuracy is about 68% in these studies. Sensitivity is around 90%, the positive predictive value is around 90%, the negative predictive value is around 78%. So probably in the coming near future, we will be looking at these algorithms that the machine is going to tell us about drug-induced liver injury. So in conclusion, I can say that LFTs still remain the mainstay for detecting and classifying liver damage. And whenever we see a DILI patient, who should always be classified hepatocellular, cholestatic, or mixed type, we should consider chronic DILI if total bilirubin and alkaline phosphatase is persistently elevated in the second month, if it's continuing. We don't forget to test HCV RNA and hepatitis E serology and RNA in patients with hepatocellular injury. And ultrasound is a must for a DILI patient, should be undertaken in all patients. MRCP may be considered for cholestatic patients, and Doppler CT scan should be in our mind, and it should be decided on case by case. Liver to continue the causative agents, it's a good idea to see the liver before going with the medicine. Thank you very much.
Thank you very much, Murat. That was an excellent talk and very informative. And I think because in the interest of time, I would move on to the next speaker. I'd like to welcome Professor Marsha Morgan from University College of London, who will give a talk on the causality assessment methods and diagnosis. Over to you, Marsha. Thank you.
My task this morning is to look at the causality assessment methods for the diagnosis of DILI, and DILI will be used to encompass drug-related, herbal, and dietary supplement-related liver injury. There is a general presumption, given the diagnostic difficulties that most people express, that DILIs are underdiagnosed. There's also evidence that they may be overdiagnosed. What is needed is a systematic, relatively simple, and pragmatic approach to aid diagnosis. There are a number of causality assessment tools, but for purposes of this talk, I decided to start from the beginning and just compile a list of the variables that might be important in this assessment process. This list is as follows. It starts fairly simply with looking at the clinical and laboratory features. We know that DILI can resemble almost any form of liver disease. Some drugs have a reliable clinical phenotype that is repeated every time that exposure results in toxicity. Others have an indistinct or variable phenotype. Drugs with dissimilar structure or mechanisms of action may share a clinical phenotype, and currently there is no standardized definition of major DILI phenotypes. So with the exception of the immunoallergenic responses, which produce extrahepatic features, there is nothing really here in the clinical phenotype that I think would help us in a causality assessment. If we look at the laboratory results, however, defining a pattern of injury using the ratio between the ALT and the ALP, I think could be important, particularly in monitoring change following removal of the potentially offending drug. So from the clinical and laboratory variables, I think that we would include the pattern of injury, but nothing else. What about the chronology of events? Well, here I think there are variables that we should include. The first is the latency. This is described as the interval between first exposure to the drug and the development of symptoms, jaundice, or abnormal liver function tests, whichever comes first. It may be difficult to ascertain this latency exactly because drugs may have been given intermittently, they may have been given in different doses, and they may have already stopped several weeks before the onset of the clinical illness. It can be assumed that if a drug is causing liver injury, then its removal would result in improvement, and this is often the case. But it may not be immediate. It may be that the liver disease is still evolving. In unfortunate cases, it may be that the liver injury has reached a point of no return with the development of liver failure, or has gone on to evolve into a chronic pattern. So while improvement following drug withdrawal supports the diagnosis of a drug reaction, it is not as secure as some of the other variables. A relapse in symptoms following a challenge, either inadvertent or accidental, is strong evidence that a drug has been causing toxicity. Rarely is this done in a clinical setting because of the dangers of a very severe adverse reaction. But it may be necessary if the drugs involved are very important for that patient's clinical care, such as oncological, antiretrovirals, or anti-tuberculous drugs. So all three of these chronology should be included in our causality assessment tool. Clearly, one of the major important things to do is to eliminate all other causes of liver injury, and they would be non-drug and drug. Acute liver injury can be caused by a host of hepatotropic viruses. It can be caused by alcohol. It can be the first presentation of Wilson's disease and autoimmune chronic active hepatitis, or acute biliary obstruction, and all of these will need to be excluded. But there are also other insults. Ischemic hepatitis, for example. This produces extremely high transaminases, comparable to those produced by the worst of the DILI reactions, and also by severe viral hepatitis. It can occur with heart failure, with a prolonged period of hypotension, hypothermia, and hypoxia. Sepsis and parenteral nutrition can result in cholestasis. These should be relatively easy to exclude. It will also be necessary to exclude causes of chronic liver disease, and these are the usual culprits listed on the slide. So it's going to be necessary to try to exclude all these other causes of liver injury. We should also exclude the effects of other drugs, long-term medication, and drugs taken in the last 3 months, prescription medication, herbal preparations, homeopathic medications, OTCs, and recreational and illegal drugs. And also, we should look at other drugs given during the illness in case there is a drug-drug interaction. So I think it's fairly clear there that we are going to have to eliminate these other causes, and we have listed the ones that are most important. The next item will be the drug's propensity to produce toxicity. And this can either be innate, relating to its drug class, its molecular structure, its lipophilicity, and its kinetics. It can also be acquired as a result of altered bioavailability and altered transformation. So in terms of drug class, the NSAIDs and the antidepressants, well known to be hepatotoxic. Molecular structure, tricyclic rings, furan moieties, and thiophenone structures. The drug kinetics, changes in absorption and changes in elimination. Thus, if there is significant GI absorption, if the elimination is via the hepatic route and the metabolites are reactive, then these are more likely to result in toxicity. Altered bioavailability can occur when there's been upper GI surgery or disease, resulting in changes in absorption, hypoalbuminemia, resulting in changes in transport, and again, other drugs for drug-drug interactions. An altered transformation of drugs can, of course, occur when there is liver disease. Now, it may also be that the drug has already been reported to be a hepatotoxin, and then you need to look and see if the pattern of injury in a given patient matches that in reported cases. But this information may not be that reliable, and it may not be easily accessible. So it's clear that we're going to have in our causality instrument something to do with the drug's propensity for toxicity. Then finally, we need to think about individual susceptibility or individual risk factors. And these divide into two: demographics and genetic. Demographics in inverted commas. So this is the list of potential risk factors that we have. And the ones that are starred are the ones that I could find reasonably convincing evidence for in terms of their risk factoring. Older age, female predominance, alcohol misuse, very definitely, liver disease, but really there's only evidence for fatty change and perhaps hepatitis B and C, not convincing evidence in terms of generic chronic liver disease. Ethnicity has a blue star because there are notable racial differences, but these primarily relate to genetic polymorphisms in the drug metabolizing enzymes. It isn't exclusive, of course. There could be other differences that are dietary, related to comorbidity, or the gut microbiome. So these risk factors perhaps should figure in our tool. What about genetics? Well, this can divide up into the genetic polymorphisms I've already mentioned and the HLA system. I'm just going to give you one example for the genetic polymorphism, and that's polymorphisms of CYP2D6, which is one of the major drug metabolizing enzymes. If these polymorphisms result in reduced or nil activity for the enzyme, then of course there's likely to be drug accumulation. The frequency of these polymorphisms varies by race. I mentioned this earlier. And if you are deficient in terms of the functioning of the enzyme, then these are the drugs that may cause problems. A lot of drugs are actually metabolized by several systems, and so they may still be adequately eliminated. But some, like perhexylene and dobriazequin, are almost entirely dependent on this system, and hepatotoxicity has been reported in those with the polymorphisms that are causing functional deficiency. We heard yesterday from Guru some really exciting work on the HLA system, those HLA types that have been associated with specific drug toxicities, and they are listed here. So what am I going to take forward from this risk factors? Well, I'm going to take forward some of the demographics, but am I going to take forward the genetics? And as much as I would love to, I don't think there's a place for them yet in a causality tool for general use. It may well be that they can be used as ancillary tests, and as such, they will be extremely useful. So I'm going to put the demography in, but I'm not going to put in the genetics, sadly. So there I have my list. Is there anything else that I considered? And yes, of course there was. I thought about putting liver histology in. I thought about blood or tissue concentrations of the drug or its metabolites, and the specific autoantibodies that you see with certain toxicities. But I didn't think that they had a place, again, in a generic, all-working tool. So this is our definitive list. Now, how does that match up with the categories that are looked at in the causality tools? A variety of them have been developed, many with point scoring, and the two that are used most frequently are the liver-specific COMS and RUMCAM. Now, they are surprisingly similar, and people mix them up and think they're one and the same. But the authors of them don't think that way at all. And there are subtle but important differences between them. So I'm going to look at the COMS first, and I'm going to add in where the RUCAMs differs. Both of them start off first by determining the pattern of liver injury using this standard tool of the R number. They then go on to look at 7 different categories: the time to onset of the event from the drug exposure, the course of the liver enzymes after cessation of the drug, risk factors but confined to age, alcohol, and pregnancy, co-medication with other drugs and herbs, a search for alternative causes, previously known hepatotoxicity, and response to an unintentional re-exposure. So the first 2 and the last one concertina into my sort of series of events. So this really matches very well to the variables that I had already come up with, but we need to look at the tool in more detail to see how close that match is. So the first question in both of them, in both of the tools, is the time to onset from the beginning of exposure to the drug or herb. And this is confined to 5 to 90 days, shorter if there's a re-challenge. And if you're within that time period, your score is 2. But this is really relatively narrow. And I think as we get to know more and more about drug reactions, and we're seeing that the periods can be very much longer, this is beginning to look as though it's lacking in granularity, and I will return to that point. The second question is the course of the ALT, and I'll show you on the next slide, the alkaline phosphatase, after cessation of the drug or herb. And this will be the percentage difference between the peak value and the upper limit of normal. And when you look at it, it's fairly tight. This has to be a decrease of 50% within 8 days or decrease within 30 days for you to score. Very narrow. With the alkaline phosphatase, it's even narrower. So a decrease of over 50% within 180 days or less than 50% in 180 days. So very little leeway and very different scales for the hepatocellular injury, which goes from -2 to 3, to the cholestatic or mixed, which goes from 0 to 2. And I am going to return to that later because it is important. So differences in the scales in relation to the time course of the change of enzymes following removal of the drug. Risk factors. This is a really weird one. So alcohol use quantified in the COMS or pregnancy gets you a score. Age over 55 gets you a score, age under doesn't. Now, at least in the COMS, it's quantified. But in the RUCAM, it's alcohol or pregnant present. So I don't know why you don't get 2 marks if you drink alcohol and are pregnant. I suppose they're trying to discourage that. But I'm concerned about this particular question. Concomitant drugs and herbs, you can only lose marks here because if there's any hint that you've been taking any drug or herb that might also have hepatotoxic potential, then you're losing ground. Now, number 5 is a bit complex. So what they set out to do is they say in group 1, there are 6 causes. Hepatitis A, B, and C. We have to look for biliary imaging. We have to check for alcohol by looking at the ALT-AST ratio and also recent hypertension. Group T2, there are also 6 causes: underlying liver disease, sepsis, and then a host of hepatotrophic viruses. To score 2, the highest you can score, you have to have eliminated everything, more or less. And then the less you're able to eliminate, the lower your score. In the RUCAMs, there are less of the hepatotropic viruses that you need to eliminate, so it's not as comprehensive as the COMS. Now, number 6 is a real problem, because in terms of information on hepatotoxicity, to get the mark of 2, you have to have on the product label that it has a potential for hepatotoxicity. So this wipes out completely this question for the herbs and the drugs that don't have product listings. They may have ingredients on the bottle, but they certainly don't have, because there's no requirement, because they're not licensed, to have a product information sheet. So this question falls down in terms of our herbs and our dietary supplements. If someone's published a case series about this, but it isn't on the label, then you don't score as highly. And then the last question is the one that's the most difficult to fathom, really, because this is the response to an unintentional re-challenge. And it is extremely complex, and it's the same on both of the instruments because it involves whether other drugs have been used. But it is there, and it is an important variable. So what about the scoring system? Well, the total score on both of them is from -9 to +14, and then they have quantified the probability. So if the score is less than 0, then you've excluded completely that this might be a DILI. And if it's over 9, that's highly probable. But there are some very hidden glitches in this scoring system. Because if there's been no re-challenge, then you reduce the range from -7 to +11. If there are no risk factors, -7 to +9. And if you remember, I showed you that the range of scoring for cholestatic or mixed injury in terms of the response of the alkaline phosphatase to withdrawal of the drug was very narrow, 0 to 2, whereas for hepatocellular injury, it went from -2 to 3. It means that if you've got a cholestatic picture with no risk factors and no re-challenge, the score narrows down to -7 to +8. So why is that important? So if you're a young man who has a boil on his back and he's given amoxiclav, and 4 weeks later he develops jaundice, the maximum he can score on both of these instruments would be 8. So his becomes probable and cannot be any higher because of the nature of the way in which the scoring is grid. So what's wrong with this? We've already pointed them out as we've been going along. I think the latency, 5 to 90 days, needs greater discerning ability. I think there needs to be greater clarity in the variation of the test results following drug cessation. It's either this or it isn't. Risk factors, they've only got 3, and the authors of the tool said, actually, if we remove those risk factors, it wouldn't change patients' category, suggesting that they think they should perhaps be removed. My argument would be that perhaps they should be expanded. Now, at the moment, to eliminate alternative causes, you do everything for everybody. But I think that that could be refined in relationship to the pattern of injury. So if your pattern of injury is purely cholestatic, then go first down the imaging pathway. If it's purely hepatocellular, then yes, you want all the viruses and all the autoantibodies, but you don't need everything in everybody, at least to begin with. So I think that could be refined. And I think that we should be adding information on the drug's inherent hepatotoxic potential. So this is my final list. I think in order to ascribe causality for a DILI, you need a detailed history of the presentation and an in-depth drug history. You need to classify the pattern of liver injury, search for alternative causes, and assess risk factors. You need to determine the drug's inherent propensity and history of hepatotoxicity. You need to monitor changes in the clinical and laboratory variables after the drug is withdrawn. And you need to check that you've got all the data you need to try to complete the COMS form, particularly if you're planning on joining a registry. So is there anything out there that I could adapt? Well, yes. There's the EASL guideline algorithm. I think with a bit of tweaking, this could do it. So it starts off with us being suspicious that it's a DILI, which is absolutely fine. Careful inquiry about exposure to all of the drugs. Have a look in the liver tox database to see any information you can about the compound that you are suspecting. Discontinue it. You should then monitor the laboratory test results post-withdrawal and at the same time assess risk factors. Then you can calculate the pattern of liver injury and search for alternative causes, to which I have added sepsis and TPN. So this guideline is a goldmine of information. It's a superbly put together document, and with a bit of tweaking, you can use the algorithm to work out the causality ascription for your DILIs. Thank you very much indeed.
Thank you very much, Marcia. That was a fascinating talk. Thank you very much, Marcia. I think it is quite methodical and then telling us how we apply the different methods and pointing out the EASL guideline. Thank you. So I'll move on to the next speaker. We all need our friend, pathologists, to guide us to do the right thing, making sure that we got the right diagnosis. So I could not find a better person than my colleague, Philip Kane, to tell us about how the liver histopathology is crucial for the drug-induced liver injury. Over to you, Philip. Thank you.
Good morning and welcome to this lecture on drug-induced liver injury pathology, which the organizers have kindly asked me to do for this meeting. Drugs and toxins may cause almost any pattern of liver injury that we see in pathology. And no pattern of liver injury is only caused by a drug. But there are some typical patterns which, if we see them, we always think about, could this be a drug which has caused it? But overall, the clinical history, serology, and the course is paramount in ascribing etiology, as it is in pretty much all medical liver disease. And the common differentials for drug-induced liver injury is really the spectrum of liver disease in general. So autoimmune hepatitis, large duct obstruction, viral hepatitis, alcohol, NASH can all have appearances which look quite similar to drugs. So what is the role of liver biopsy? Well, it's not mandatory for diagnosis. You'll know that. The majority of cases you'll diagnose on the clinical appearance and the serology and the course of the patient or liver enzyme tests. But liver biopsy, in cases where it's doubtful, may help confirm a diagnosis of DILI. It may also provide pointers to consider drugs where this was not suspected clinically, and that is where we can perhaps provide our most use. It also is may be useful in identifying underlying or coexistent liver disease where the drug has precipitated the current presentation, but there is significant underlying liver disease of some sort. And it may also help identify prognostic features in what will happen with the patient. This paper was published in 2018 by Kleiner and colleagues from the DILI network in America, and there were a large number of patients, many of whom had pathology, and Kleiner did a very detailed histological analysis on these patients, going into many different points and grading lots of different criteria, and came up with 18 different categories of or patterns which could be seen, which seems like quite a lot. But the vast majority of cases fell into one of these top 5 patterns. There was the acute hepatitic, where there was predominantly lobular inflammation, but without much cholestasis, with or without necrosis. The chronic hepatitic pattern, where there was a portal predominant inflammation, not necessarily with fibrosis, but again, if there was any cholestasis, it was put into category 5. The acute cholestatic pattern, where there was bilirubinostasis, but with little or no portal inflammation or lobular inflammation. The chronic cholestatic pattern, where there was cholate stasis and changes of biliary interface activity, with or without copper accumulation and bile duct injury. And then pattern 5, which was any case which didn't have features of pattern 4, but did show cholestasis with inflammation of any degree, either portal or lobular or mixed. And so a lot of patients ended up in pattern 5. So I think this was a very good classification and a good attempt at classifying drug-induced liver injury, but there are certain problems. One of it is that there are too many categories to remember, and the categories overlap a lot. But then the majority of the cases do fall into the top 5 categories. There is also a potential for confusion of clinical histological terms, and I think this is the biggest problem with this classification, which I'll go into now. So acute hepatitis and chronic hepatitis, if a pathologist diagnoses it, I think there's a risk that the clinician might be somewhat confused by this, because clinicians, as far as I understand, will use the terms acute and chronic for the clinical course of the patient, and pathologists are using it for pathological features. So acute hepatitis really is describing lobular hepatitis, so why not just call it lobular hepatitis? Chronic hepatitis is referring to chronic inflammatory cells in the portal tracts, which actually can be a very early event in viral hepatitis and autoimmune hepatitis. Doesn't necessarily imply the patient's having a chronic course. So I think it's better to just call this portal hepatitis. Again, acute cholestasis, another term for it is bland cholestasis, and I would prefer to use that because that's what we're seeing. We're just seeing bilirubinostasis without much inflammation. Chronic cholestasis does imply that there is some degree of chronicity in that you often have copper-associated protein with it and some which presumably takes a bit of time to develop. But the timing again is variable, and you get bile duct damage pretty quickly and near ductular proliferation pretty quickly. So I think, again, I would prefer to call this biliary interface hepatitis. And then cholestatic hepatitis, the term is fine, implies inflammatory activity with cholestasis, but we probably need some tightening up as to when to use this as opposed to, say, lobular hepatitis with just a tiny bit of cholestasis. Would it all go into cholestatic hepatitis? And this just shows from Kleiner's paper, I've made this diagram which shows the clinical categories that were used and how that intersects with the pathological categories that were used. And you can see that a lot of the acute hepatitis goes into cholestatic hepatitis. Some goes into lobular hepatitis, some goes into portal, or what Kleiner called chronic hepatitis. So that kind of doesn't really gel. And the same with the other categories. They are distributed through the different pathological categories. So I'm not sure whether it actually requires some clinico-pathological definition of or categorization, or whether we just accept that the clinical categories and the pathological categories may be distinct. So I'm just going to go through these categories in a bit more detail just to briefly show you the pathology. So lobular hepatitis or acute hepatitis in Kleiner parlance shows lobular inflammation with lobular disarray. There may or may not be necrosis, as you can see in this picture where there's central lobular necrosis. And there shouldn't be much cholestasis or no cholestasis if you're following it strictly. The differential for this would be an acute viral hepatitis and acute onset of autoimmune hepatitis. So although classically autoimmune hepatitis gives you chronic inflammation in the portal tracts with interface activity, in the acute presentation sometimes you get a predominantly lobular appearance with necrosis around the central veins. So that would be the main differential. For portal hepatitis or chronic hepatitis in Kleiner's terminology, there's a portal predominant inflammatory infiltrate. There's usually interface hepatitis with this, where you're getting disruption of the limiting plate. There may or may not be a lot of lobular inflammation, and there may or may not be fibrosis. So obviously, if it's an acute presentation clinically, there's unlikely to be fibrosis, but there may be fibrosis present in longer standing cases. There shouldn't be cholestasis, because if there's a lot of cholestasis, we'd put this into the cholestatic hepatitis pattern. And the pathology of this would be very similar to autoimmune hepatitis. You may get plasma cells, rosettes, etc. And in the one category of portal hepatitis due to drugs, you may even get positive serology, and as we know, some cases of drug-induced hepatitis do go on to something which is very similar to autoimmune hepatitis. I've just put in this question about the role for lymphocyte typing, because there was one paper which suggested that you could type the lymphocytes in the portal tracts, and in autoimmune hepatitis they're more likely to be B cells, and in drug-induced liver injury they're more likely to be T cells. And we have tried this on occasion, but it probably needs a bit more work to define it. Bland cholestasis or acute cholestasis shows cholestasis in the hepatocytes. You can see it in the canaliculi over there with some rosetting as well, and some in the hepatocytes as well, but with minimal inflammation. And the differential for this would be your genetic diseases, benign recurrent intrahepatic cholestasis, which is of course a benign disease which doesn't go on to significant liver injury, and progressive familial intrahepatic cholestasis, which it looks pathologically quite similar to BRIC, but can go on to develop severe inflammation and eventually cirrhosis. Hodgkin's lymphoma, or even non-Hodgkin's lymphoma, can sometimes present as a perineoplastic with bland cholestasis, so can sepsis. And large duct obstruction is always an important differential. Usually there's some inflammation in the portal tracts, but with that as well. But then bland cholestasis at one end of the spectrum probably does have a greater degree of inflammation. So there is some overlap there. Biliary interface or chronic cholestatic pattern often shows bile duct injury and sometimes bile duct loss. There is portal inflammation, which may be a mixture of lymphocytes and neutrophils, and a prominent ductular reaction. And this is a picture showing a CK7, which shows biliary metaplasia in the periportal hepatocytes, which is one feature of ductal disease of any ductular disease of any sort. And then cholestasis with ballooning of the cells around the portal tract and sometimes Mallory hyaline in them. And copper-associated protein. You can see this is a Shikata showing this black copper-associated protein indicating a chronic cholestatic pattern. And the differential for this would be your biliary diseases, PBC, PSC, but unlike those diseases, this may be reversible. So even if there's bile duct injury, it may still be reversible with time, and it's difficult really to predict which cases are going to be entirely reversed when you stop the drug, or which may go on to some sort of vanishing duct syndrome. And then last of the big patterns is cholestatic hepatitis, where you've got cholestasis any amount together with more than minimal inflammation. So the inflammatory activity is often in the lobule. There's necrosis, which may or may not be present, but you can see it in this case. And you can see the yellow pigment, the cholestasis, and lobular inflammation with spotty necrosis. The differential for this would be depending on which side of the spectrum it's on. If it's on the heavily inflamed side of the spectrum, you could be thinking about autoimmune hepatitis. If there's a lot of cholestasis, it would push you towards drugs, but you can get cholestasis in autoimmune hepatitis. Viral hepatitis, particularly hepatitis E, which is now the most common cause of acute hepatitis, could look very similar to this. And large duct obstruction, if it's on the side of the spectrum where you've got fairly mild inflammation, largely in the portal tracts, then large duct obstruction would be could be a differential, and it's something which always needs to be remembered when you've got cholestasis. From the rest of the patterns which you described, I'm just going to pick out the two which I think are most important. There's the vascular pattern, which is where you get sinusoidal obstruction syndrome and or nodular regenerative hyperplasia, and it's caused by endothelial cell injury. The changes are variable. It's a very common pathology which we find in patients who've undergone liver resection for colorectal cancer metastases where they've had prior chemotherapy. And in those sort of settings, it probably doesn't cause a great deal of serious liver disease, although at the more severe end of the spectrum, it can be responsible for liver failure post-surgery. But the most serious pathology, veno-occlusive disease, is generally seen in hematological patients with bone marrow transplant conditioning, and it can cause a severe life-threatening Budd-Chiari type clinical syndrome. And here's a picture of it, where you get the central veins which are becoming obliterated with fibrous tissue and red cell extravasation into the space of disc and into the sinusoids and dilated sinusoids, and the liver plates looking very thin and atrophic around that area. And this can, and as I said, this can be life-threatening. Steatotic patterns are fairly uncommon as a drug-induced cause. Methotrexate is one of the most famous to cause this, and with or without associated fibrosis. Tamoxifen is probably the best evidence for any drug causing steatosis is for tamoxifen, and amiodarone is well described as well, sometimes with phospholipid deposition. Microvesicular steatosis is much less common, and it implies severe mitochondrial injury, and is described with valproic acid, aspirin, and nucleoside analogs such as didanosine as antivirals, and that can cause liver failure similar to the severe disease found in fatty liver of pregnancy. This is an example of methotrexate, and you can see the typical features of steatohepatitis. There's obviously in this case it's nodular, so there's advanced fibrosis in this case, but there's the typical fatty change, macrovesicular, some microvesicular, and ballooning. And this is an example of microvesicular steatosis, where you've got the cytoplasm which looks rarefied, and you can just about make out little vesicles at high power together with cholestasis. So, in summary, one should think drug if the pattern doesn't fit with the clinical expectation. If there are features of large duct obstruction, but the ultrasound is normal, or the clinicians assure you that there is no large duct obstruction, then it may well be a drug which is causing that sort of pattern. If there is prominent portal hepatitis, but with lots of cholestasis, then drug should always be on the list. If there are lots of microgranulomas in the liver parenchyma, that's one feature which is well described with quite a number of different drugs. And if there are lots of eosinophils. So eosinophils are often used throughout the body to indicate that it might be allergic or drug reaction. Not as commonly seen in liver DILI, but if you do see a lot of eosinophils, then drugs should definitely be on your list. This is a case of allopurinol drug-induced injury, where you've got a little microgranuloma in the parenchyma close to the central vein. And a number of drugs cause this particular appearance. And this is a case which we've had recently, where there was a lot of eosinophils in the portal tract, which was due to a non-steroidal drug, celecoxib. We also have to think about less common causes to exclude. This is a list from a recent paper in histopathology, also by Kleiner, which was a review, and these are just a number of diagnoses, or a whole list of diagnoses, depending on the pattern that we see, that we have to also just think about and exclude. So what about the severity of injury? Well, we can tell you how much necrosis there is, and that does give an indication to how severe the injury is, and the amount of fibrosis obviously is very important. It may indicate that there's underlying disease of some other sort, or that the drug injury has been going on for a long time, and obviously has implications for the patient getting better. Microvesicular steatosis, we already mentioned, is a much more severe pattern, which if we see, we need to communicate that. If there are lots of neutrophils, it may indicate that it's a more severe injury, and if there's a prominent ductular reaction. The question about bile duct damage, in Kleiner's paper, this didn't correlate very well with any long-term problem, but I think it depends on how much bile duct damage there is, and obviously if you've lost bile ducts, that probably is going to be severe. And interestingly, presence of eosinophils and granulomas tend to be positive features for the patient recovering without any problem. So one always has to remember that drug-induced liver injury may occur on top of some underlying disease, and pathologists should always consider this. And NASH in particular is so common that if the clinical history indicates some sort of acute presentation, then it is likely that any NASH which is present is an underlying cause and not underlying problem, not the reason for the current presentation. And certainly if you get cholestasis, that is unlikely, that is almost certainly not going to be caused by non-alcoholic steatohepatitis, so there probably is another cause for that, in addition to any underlying disease that may be present. One obviously has to think of the timing of drugs, and pathologists need to think about this in combination with the clinician, and also remember supplements if there's no obvious drug which is declared. And when one knows what the list of drugs are, one has to compare the findings of the suspect drugs to the published patterns, and there are long lists of tables with drugs and their patterns, but in recent times we've been fortunate to have this website, the Liver Tox website, where you can just put in your drug, the name of your drug, and it will give you some information about that, including any pathology and any pattern that has been shown with that drug. So these are some of the key references which I've used, and I hope you found the talk of some use to you this morning. Thank you.
Thank you very much, Phil. Thank you for the exciting morning, and then for the causality and how we diagnose, including the liver histology. I think we got quite a few questions from the audience. So I'll pass it over to Professor Murat to start the questions. Over to you, Murat.
Okay. Firstly, thank you, all speakers. All presentations were great. For Bülent, one question from Cemal Nuri Erçin. Thank you for this excellent talk, as usual. We know that in cholestatic cases, returning the test to normal takes time. You said if it doesn't decrease in 2 months, we can think this is chronic. Is this time short? What do you think? The 2 months is short. Cemal Nuri Erçin asked you.
Well, yeah, I agree with him. I mean, when we're talking about cholestatic liver injury, I mean, it takes time for the liver to get back to normal. So it is a protracted course. Some authors believe it should be 6 months. I mean, especially for performing a liver biopsy and for causing a chronic DILI case. In some authors believe that it's for acute hepatocellular injury, it should be 60 days. And for cholestatic injuries, it should be 6 months to consider chronic drug-induced liver injury. But I mean, these are not strict rules. I mean, we should always go with, case-by-case decisions and decide according to the case, clinic, liver biopsy, and others information that we get from the patient. But I agree. Yes, it is a little bit short.
Mm-hmm. Another question from our TASL president, dear Professor Ramazan İdilman, for Bülent. Early liver biopsy perform. More information get about the outcome. He asked the liver biopsy timing.
Well, I personally think, we're waiting too long for liver biopsy. We're waiting for the liver to get back to normal, and we're losing days and weeks in this way. And then suddenly the patient is too sick to have a liver biopsy, or maybe the liver damage is way too far, and we're not able to cure the patient in a better way. So I personally, in my daily practice, I prefer doing liver biopsy in early stages, and I decide mostly according to the bilirubin level. If it starts getting a little bit highish, and then if the INR is getting a little bit high, then I don't usually wait too much. And especially for cases like autoimmune hepatitis and cholestatic ones, waiting a little bit will lose us very important time. So I agree with him. I think we should start performing liver biopsies more earlier, especially in cases where bilirubin is getting a little bit elevated and the liver functions are not working well. That's my personal opinion. I don't know what the other authors will think.
Maybe we ask this question, Professor Philip. Do you prefer the early biopsy or late biopsy?
From a pathology point of view?
Yes.
To be honest, I don't know. I think that's really a clinical question for you to decide. Obviously, I think it just depends on what your clinical question is. Really, if you're asking about about whether there's likely to be established or serious long-term liver damage, then probably later on. But if you wanted to know whether there's likely to be a drug causing it, probably early on.
Okay, thank you, Philip. Okay, thank you. Please, continue the questions.
Thank you very much. So I got a question for Professor Marsha Morgan. Marsha, Ramazan was asking, when do we calculate the UCAM after the drug exposure? Would you be able to address that for us? Thank you.
Yes, of course. I think this is a really very important question. Because, of course, to calculate the scale accurately, you need the information. And that information is going to take you a week, maybe 2 weeks, if not longer, to collect. The advantage of these, if you like, these sort of composite forms, is that if you've got it in front of you, it prompts you to collect the data prospectively that you are going to need eventually to finally sort of firm up your diagnosis. So they're not necessarily going to give you an answer in the first couple of weeks. you're going to be doing that from all the other things, from what you're actually observing clinically, what you're actually finding when you're taking the history from the patient. But to have the form in front of you to prompt you, I think is going to be very, very important. So I think that's their use in the early phase is, let's make sure that we're actually getting the data as accurately as we can, and then we can round it up at the end and confirm or otherwise our diagnosis.
Thank you very much, Marcia. That was an excellent answer. And I got to move to Philip. There are two questions for you, Philip. One of the question is we always ask that there is an interface hepatitis in the DILI, which is also in the autoimmune hepatitis. How can you differentiate between these two in the clinical setting?
Well, I think that is one of the differentials, which is almost impossible to differentiate histologically. You can see a DILI which looks almost exactly the same as autoimmune hepatitis, and I mean, I think there are some clues. I mean, if there's a lot of cholestasis relative to the amount of inflammation, then I think you're looking more towards a drug. I mean, as I said, you can get a lot of cholestasis with autoimmune hepatitis, but usually then it's a very severe disease. So I think that is the only sort of thing that I can think of that would really point you in one way or the other. But I've seen liver biopsies of DILI which would be perfect for autoimmune hepatitis.
Thank you, Philip. And I got another challenging question for you as well. And how could we differentiate between the non-checkpoint DILI and the checkpoint DILI, Philip? That is an excellent question. Over to you.
It's an excellent question, and again, it's probably impossible for pathologists to answer that. I mean, if you say checkpoint, I think the best way to do this is the patient on checkpoint inhibitors or not. In which case, it's likely that the disease is caused by them. Again, they tend to cause something which looks quite similar to autoimmune hepatitis quite often again with more cholestasis, but obviously that is now becoming one of the biggest problems, or the most serious problems with drug-induced liver injury is checkpoint inhibitors, and we probably need to learn quite a bit more about that.
Yeah, I know. I totally agree. I mean, that is the reason we probably need more research using the new tools like spatial transcriptome and single cell to understand more about these, how to differentiate this two condition.
Sure.
So I got another question, probably that is for the whole panel. It's an excellent question. And is there any evidence in using the Pavrinex intravenously in DILI? So I'll open the question to the floor. Murat, I'll start with you. Would you use it?
Yes. No, we don't use this.
What about you, Bulent? What do you think? Would you use a Pavrinex when somebody came in with an acute severe DILI? Is there a rule for that?
Well, no. I don't use it. Also, well, I don't know. I mean, I'm just curious what the other will tell us.
Yeah.
I mean, I think if the patient isn't eating and you're actually trying to supplement their diet, you could do that adequately with oral vitamins. I don't think you need to have an intravenous supply of Pavrinex. I can't see a particular reason for it myself.
Okay.
Thank you. Thank you very much, Marcia. So I think we all had an exciting morning, and probably in the interest of time, we should close the section. Both Murat and myself, we would like to thank all our speakers. Thank you very much for your time and excellent talks. And I think we see each other again. And I think I'll hand it back to the main audience. Thank you.
Thank you very much. Goodbye.